Good evening, everyone, and thanks for joining our men's health webinar. We are so excited to have the opportunity to share important men's health education with this group tonight. My name is Jose Alvarez, and I'm the host of tonight's event. I'll start with a couple of quick housekeeping items, then I'll introduce our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask can only be seen by myself and the speaker. We encourage an interactive presentation, so if you like to ask any question, please type it in the chat box at the lower part of your screen. And we'll save time at the end of the presentation to answer as many as we can. Tonight's webinar will be presented by Dr. Jonathan Beilan, a urologist and men's health specialist at the Advanced Urology Institute. Dr. Beilan, I know your time is in high demand, and I thank you for your willingness to be with us this evening to share education with the community. I'll turn it over to you.
Great, thanks, Jose. Well, thank you to all of our attendees and our patients and partners alike who have signed on today. I have just under an hour to go through some broad strokes with ED and talking about the high-level things in terms of causes, diagnosis, and treatments. And then we're going to move on to talk about urologic incontinence, male stress incontinence in particular, and also the diagnosis treatment options thereof. And I'm going to really try to set a decent pace so that way we have some time at the end. Please do type your questions as they come along and we will answer them at the end. I'm definitely going to save some time afterwards, so I hope that we get some back and forth dialogue going with that at the end of the presentation. That's always my favorite part. So here are some screens, some good online resources are edcure.org, as well as the fixincontinence.com. These are two resources that can be assistance to you and I use every day for my patients. A couple slides about me. I specialize in erectile dysfunction, male sexual function, male fertility, as well as things like men's health, which encompasses Peyronie's disease, testosterone, replacement therapies, and certainly urination, BPH, and incontinence with that. In terms of my background, I'm originally from the Gulf Coast, from Pasco County, Florida here. Went as far as UCF in Orlando for undergrad and medical school. Made it out to Baylor in Houston, which is the Red Star, finally out of Florida for 1 year to specialize further after my urologic residency to specialize in this men's health, male sexual function, urinary continence, etc. And now I get to come back to Pinellas County and practice what I love. So I'm a pretty lucky guy. All right. So diving right into it, we're going to start off with erectile dysfunction. And the definition for ED has actually changed over the decades. Currently, it's more of a subjective definition set forth by the patient. Simply put, it's the inability to achieve or maintain an erection firm enough for sexual intercourse or satisfactory for sexual pleasure. Now, obviously, everyone has a different definition of that, but it doesn't matter. If you feel like you're suffering in the categories of achieving an erection, maintaining an erection, or just with the overall rigidity of the erection, if you say yes to any of those three questions, then boom, you have a diagnosis of erectile dysfunction. It's obviously very common. About 1 in 5 American men over 20 years old will experience ED at some point in their lifetime. And more than half of men over 40 have some degree of ED. So those of us who aren't talking about it likely, do have an element of it. So this is something that is underserved in our population, and we're trying to change that. Just a slide here on the physiology, the erectile process. This is both a vascular and a neurological process. Really, it starts with the nerves and the nitric oxide pathway. You'll see in the flaccid state, the smooth muscle is contracted. And when these nerves are activated, the smooth muscle relaxes, allowing the corporal cavernosal arteries to expand, and you get a healthy inflow of oxygenated blood. You're pressurizing the system, these corporal cavernosal spaces. And in doing so, these venous sinus complexes are compressed. So you're keeping the blood there in the erection. So oftentimes, in terms of diagnosing ED, we perform vascular studies to assess the patient's response to a given medication, assess their arterial response, assess their venous response, and that tells me a little bit about the physiology of their erection. Very telling. Some of the most common causes of ED, number one, vascular. This pertains to my patients with high blood pressure. This pertains to my smoking population. Number two certainly is diabetes. This has the double whammy of both working on blood vessels and nerves. And then thirdly is medications, coming again back to blood pressure medications. Some psychiatric medications certainly can be incriminating to both erections and ejaculatory function. So those are the big three: vascular, diabetes, and medication-related causes. Diabetes is something we see with every day. And, just simply put, the diabetic population is not quite as healthy as our general population. And this is one sequela from that. So diabetic patients are less likely to respond to oral medications such as Viagra or Cialis or other pill therapy. And their ED is typically more severe at a young age. So if I see a bad diabetic, or if I understand someone had even a brief history of uncontrolled diabetes for a brief point in their life, I'm in the back of my mind thinking, do we need to get more aggressive with our diagnosis, with our therapies, and moving this patient forward to getting them their sexual life restored? So, ED, this is a little bit repetitive, can certainly be a result of having diabetes. Healthy blood vessels are really at the crux of healthy erections. And so 60 to 70% of patients with diabetes will have some form of nerve damage or neuropathies. And this can also affect the nerves and nerve endings to the penis as well. So this nerve ending issue is partly why these pills fail so readily in my diabetic guys. So in addition to that, we have advancing age, we have glycemic control, we have concurrent vascular disease, as well as a healthy medication list also within our diabetic population, such as diuretics or blood pressure medications. So we don't want to ignore how important good diabetic control can be in restoring your sexual function. Heart disease was certainly a big factor up there, as well as the vascular disease. So one of the biggest things, and when I first came to practice in the Clearwater Largo area, I would go around visiting primary care offices and visiting cardiology offices and impressing upon them to please ask your patients about erectile dysfunction, because it's such a good screening tool for the cardiac population. There is very good evidence to suggest that symptoms of heart disease may develop 2 to 3 years after erectile dysfunction. So if a patient has ED, if a 47-year-old gentleman has erectile dysfunction, you have to be wondering why. And is this a first early sign that this patient could have coronary artery disease? And indeed, about 70% of cases down the road, that patient will have either a cardiac event or be found to have coronary artery disease that could be screened, diagnosed, and treated, of course, in addition to treating their sexual function. And the reason for this is just simply anatomy. The penile arteries here on the left side of your screen are multiple times smaller than the main arteries of the heart. And even of course, of your carotid artery and your femoral artery being one of the largest in your body other than your aorta, your penile arteries are smaller. So if a patient has plaque buildup or arterial disease, you will see it first with their erections and often second with their cardiac function. And I think that's so telling in how the world of urology crosses over with the world of cardiology. So certainly when I'm counseling patients, I'm trying to look through their comorbidities. I'm trying to look through their medication list, and we're talking about their lifestyle factors as well. And this, simply put, being healthier does give you a healthier erection. And I say the similar sentiments for my fertility patients. Your sexual function and your fertility are reflections of you and how healthy you are as a whole. It's hard to just keep an isolated aspect of your health aside. So I do talk about stress, I talk about smoking, we talk about diet, exercise, weight loss, etc. So important. Another piece that goes with that is low testosterone. And finally, as of a couple of years ago, the AOA has included testosterone in our erectile dysfunction guidelines, saying that a new erectile dysfunction patient likely warrants a cardiac workup and testosterone screening. So approximately 4 in 10 men over the age of 45 may be found to have low testosterone. So that's a big piece of my practice in screening for low testosterone, replacing when indicated, and working to fight the symptoms of what we call hypogonadism, such as low energy, low libido, fatigue, mood swings, etc. Certainly a big piece of my practice. Just real briefly, treatments for low testosterone range from topical agents to injection therapies. We do have some oral medications now on the market, as well as testosterone pellets, which are subcutaneous almost like a grain of rice. We can put a half a dozen of those under the skin and let the body absorb those slowly over time. So we do have multiple avenues to replace testosterone if you're a candidate. So erectile dysfunction and prostate cancer treatment. These are a big theme that every year at the Sexual Medicine Society meetings, we're talking about how can we improve the lives of our prostate cancer survivors. And this is because here from an anatomical standpoint, you see the prostate is intimately associated with the nerves and the pelvic plexus that comes from the spinal cord through the pelvic plexus to the erections themselves. And those nerves are intimately associated with the prostate. So when you're removing the prostate, you're certainly affecting the erections from not only a vascular standpoint, but also a neurologic standpoint. And the sexual function in these prostate cancer survivors, it really has a wide range. It affects anywhere from 25 to 75% of men, which is just a huge range. And radiation is not much different, although the timing of sexual dysfunction and comparing surgery to radiation certainly is different. But in the end, if I have a prostate cancer survivor, whether he got radiation or surgery, I'm thinking in the back of my mind, how can I be more aggressive? Do we need to think about injection therapies, penile implant therapies? What can we do to definitively restore function and give this patient the spontaneity and reliability he needs? Peyronie's disease is just now gaining some traction and still widely underserved in the male population. Peyronie's disease is a term for penile curvature. Perhaps you or someone you know has it and didn't know the proper term for it, but it's a plaque buildup of fibrotic change of the tunica albuginea, which is a strong yet elastic fibrous layer within the penis that is supposed to expand and contract with your erections, trapping the blood flow within the corpora cavernosum and allowing the rigidity of the erections to take place. Now, when you have a fibrous plaque buildup here, you can have some scar tissue pull the penis in one direction or another, or maybe multiple directions. Maybe it does more of a serpentine bend, or perhaps a non-traditional curve where you have a wasting or bottleneck deformity of the penis. All of these types of anatomical changes are associated with Peyronie's disease, which goes hand in hand with erectile dysfunction. So when I'm talking to a patient with possible Peyronie's, I'm trying to get a sense of, is this a curvature issue? Is this an erection rigidity issue, or perhaps both? And what treatment can get them to the goals that we are looking for? Alternative treatment options, these are all considered experimental, so tread lightly. They're not included in the guidelines yet. Actually, I should say that they are included with the underscore that they are experimental, investigational only. My practice indeed does offer low intensity shockwave lithotripsy, and I put a big asterisk by it when I talk to patients about it. So don't believe everything you hear on the radio. Make sure you're talking to a urologic professional who is clean cut with you, lays out all the disclosures and lays out the risks and benefits of this type of treatment. All right, so treatments that are more mainstream, and this is my everyday practice. I actually have a poster very similar to this up in each of my exam rooms. Injections, oral medications, vacuums, suppositories or intraurethral agents, and penile implants we'll focus on at the end here. So just a brief slide on each of them. Pills, everyone's heard of the little blue pill or Viagra or Cialis. They can be quite effective. Up to 60–80% of patients can respond favorably to these. And this is generally where I start. When I have a new patient who has not tried any medication yet, doesn't have any contraindications, generally we're starting with pills. I do talk about side effects, which affect almost 50%, if not more, of patients who try them. These are nasal sinus congestion, flushing, headache, upset stomach or gastric reflux. Very common to experience those side effects. Certainly one of the major contraindications are nitrates or nitroglycerin. So if you're on certain cardiac medications, you simply cannot have the pills. But in the proper patient, they can work well. So injection therapy is probably the next most common in my particular practice, where if pills are failing, I'm talking to them about vacuum devices, intraurethral gels, and injection therapies. And of those, I probably have the most patients on injection therapies. Basically, you're self-injecting a medication using a small insulin needle. I know it's daunting, but it's a very small insulin needle, typically 29 or 31 gauge, and you're to inject 20 to 30 minutes ahead of sex, and can be very effective in the right patient. Main side effects are penile pain, not even related from the needle, mainly from the medication themselves, and an achiness to the erection, And certainly the number one thing I hound my patients on are prolonged erection or priapism. That's the main danger with these, is that if they work too well, or if you overdose the medication, you can have a persistent erection over 4 hours, and that's a true medical emergency. So we need to know how to handle that. So, most commonly, the majority of patients do not last a year on this therapy, whether it's because of pain or side effects, or they simply don't work, because finding that magic dose is a bit of a trial and error situation, and not everyone has the luxury of a situation or relationship where they can have multiple failed sessions and still be okay. Vacuum erection devices, this is where you fit an external appliance over your penis and push a button or use a manual pump to create that vacuum and suck blood into the penis, usually used in combination with a constriction band or a cock ring to try to trap the blood in place. I don't use this too commonly as a monotherapy. Most of my patients find it very cumbersome, not very spontaneous, but I do use it very readily, more for rehabilitation maneuvers, for my prostatectomy patients, for my Peyronie's disease guys, and patients who have had a history of radiation and are dealing with fibrosis. Maybe we use it as a preoperative maneuver to increase their elasticity of the tissues before surgery. So something that I do use, but typically not as my primary monotherapy for ED. And finally, urethral suppositories. We do have this in compounded medications as well as brand name. The brand name is Muse. It's a pellet. And the main side effect here is that it can cause pain, urethral burning, and sometimes some spotting or blood down the urethra, because you're putting a small pellet down the pee hole. Usually when I prescribe this, I'm using a compounded gel form, because I actually get it compounded with a lidocaine solution. I gotta admit, that being said, even with the lidocaine, still a lot of discomfort as that medication is absorbed through the urethra and travels to the corpus cavernosum where it's actually active. So I do prescribe it, but probably not as common as my injection therapies. And finally, the gold standard out of everything we've offered, this is likely the most common, interestingly, to be covered by insurance, is a penile implant, a surgical approach. And this oftentimes, I put this picture up in clinic as well, and guys look at it and it's very daunting to have all this plastic within the tissues, but in reality, you're giving the patient an invisible, meaning under the skin, all internalized device that can restore the rigidity of the erections and do it quite well. The satisfaction rating here is 98% for both patients and partners. And the main downside is that it is essentially an irreversible surgical fix. So you do need to have a clear understanding of what this is and a clear understanding of what it means to go to the operating room and heal properly from this. So usually these are the three-piece prosthesis where you have the cylinders, which fill with saline. You have the pump, which controls the cylinders, and the reservoir is down behind the pubic bone, typically next to the bladder, which fills with saline. And you can control everything just through pinching this bulb down here within the pump itself. So these have been originally invented in the early 70s and have undergone multiple iterations, from semi-rigid or permanently rigid implants now to inflatable, which is certainly more physiologic. We have a couple slides coming up on the insurance benefits, et cetera, but I wanted to talk a little bit about the surgery here while we have this slide up. Usually I can put in a penile implant through a small incision just above the penis, probably about yay big, depending on the patient's body habitus, how much of a belly he has. We can also do via penoscrotal approach, which is an incision just below the penis where the penis meets the scrotum. Regardless, either way, surgery should take about an hour, probably a little bit under an hour, and you go home the same day. No Foley catheters, meaning no urethral tube. I do leave a drain behind. My particular protocol calls for a drain typically for 3 days post-operatively. And generally, patients are having sex by 4 to 6 weeks later. We do have a 2-week checkup just to make sure you're doing well. I give you some homework in terms of inflating, deflating the device, etc. But when I see patients back at that month or month and a half visit, they're off to the races, and we have a little graduation ceremony. It's a fun time in clinic when we have healed well from this penile implant surgery. So, the procedure itself, I just went through a little bit about this, just under an hour, and you'll go home the same day. So the cost and coverage, I always laugh with my patients who are struggling to have pills paid for. Most insurance companies, not all, but most do not cover vacuum erection devices. None of them cover the injection therapies. So it's interesting that most insurances do indeed cover a surgical fix, which seems the most drastic. But in reality, I think what the insurances are thinking of is, what is the de facto answer for this patient? And that's the implant. And if you have your surgery and you heal well, you're off their list. You should not need any additional maneuvers. And so that's kind of the gold standard of treatment, and certainly has the highest success and satisfaction rates there. So, I mentioned the success and satisfaction rates. The durability of the implant is also unparalleled. I tell patients on average, this should last you a good 10 plus years. So if we can undergo a minimally invasive procedure that takes just under an hour, and I give you a decade of good sex, I think you're going to be quite happy with me. Generally speaking, if these devices fail, they simply leak saline into the body absorbs it, it's no problem. And you'll come into clinic and say, hey doc, this implant doesn't do anything when I'm pumping it. And we make a decision whether or not we want to revise or replace the implant. And that's that. The biggest thing here when I'm talking about implants is it really is the best answer in terms of restoring the reliability and the spontaneity of sex. There's no worrying about the dosage that you're drawing up in your needle. There's no worrying about the timing of your pills or the side effects of this medication or that. When you want an erection, it doesn't matter where you are, who you're with, what time of day it is, what you ate or drank. You reach down, you pump up the implant, you're going to be rock hard, and that's that. So it is life-changing for my patients and their partners. Now, it's certainly not without risks. The number one and number two risks I always talk about with this is infection. We are putting plastic inside the body, all contained underneath the skin. And God forbid bacteria latch onto this device. That's one of the few things that can sink the ship. Of course, this is a very rare side effect or risk. This is about 1 to 3%. So it's very rare. Certain situations such as, really brittle diabetes or a more complex surgery that maybe corrects Peyronie's disease, that can change the risk profile. And we talk about that before surgery. But in general, for a standard case, 1% risk, you're going to do quite well if you take the time to educate yourself and understand what it means to heal post-operatively. All right, so just in terms of summary, I always impress this at the end of the erectile dysfunction sessions. No matter where you are in your ED journey or in restoring your sexual function, number one, don't lose hope. Number two, find a professional who knows how to diagnose you as a whole and look at every aspect of your health. And number three, talk through the multitude of options ranging from medical to surgical and figure out a solution that's right for you and your partner, because those solutions are out there, and it's just a matter of finding what's right and what's comfortable for you in your life. All right, so that's a brief overview of erectile dysfunction. I'm going to try to whiz through the urinary incontinence slides here. I'm hoping that that presentation on ED generated some questions, and fire those off in the chat box at any time so Jose can start tabulating those. All right, so male stress incontinence, and this is important to know, we're only talking about stress urinary incontinence. So what is that? That is basically with a stress maneuver, such as coughing, sneezing, laughing, lifting something heavy, changing position, getting in and out of the car, getting out of bed, leakage at those times. Not necessarily associated with urgency incontinence, which is more of a bladder spasm type of event. Stress incontinence itself affects over 500,000 men within the United States. So this is something that's very common, particularly common in our prostatectomy and prostate radiation survivors. So, the bladder is basically just a storage unit. And here you can see my mouse here. The bladder is just a storage unit. And when you urinate, it's a complex coordination of both relaxation of the pelvic floor muscles, contraction of the bladder muscle, and relaxation of the sphincter muscles to allow urine to pass through the prostate, through the sphincter, and out of your body. And so when that sphincter is dysfunctional, this is when you'll have a lack of continence, a lack of control as you are doing these stress maneuvers. All right. So again, as I mentioned, it's strongly correlated with prostate cancer surgery itself. Up to 50% of men report leakage immediately following surgery. And in about 15%, 10, 15%, depending on what kind of procedure you had done, this may be persistent after a year. And certainly any concurrent neurologic disorders or an enlarged prostate during surgery or radiation, et cetera, can complicate that picture. But it really is an important aspect of prostate cancer survivorship and indeed just health in general. Perhaps you're not a prostate cancer patient, but have stress incontinence. These individuals do have psychosocial problems that I think are so rewarding when we can correct this issue, that these patients are often amongst the happiest we have in finding their solution to ED and stress urinary incontinence. So in terms of options, wants to talk about prostate cancer. So SUI and prostate cancer treatment connection, we mentioned how closely intimate those nerves and the pelvic plexus and the prostate are. And when you're eliminating the prostate from the picture, you're affecting those nerves. You're affecting the nerves not only to the penis, but also to the external or voluntary sphincter. And we mentioned that 15% statistic that this can be persistent at a year out. So in terms of treatment options, we have behavioral modifications, certainly pelvic floor therapy, which extends well beyond just Kegel exercises. Doing those contractions are excellent, but pelvic floor physical therapy, for example, can encompass trigger point release, biofeedback, manual stimulation, and neuro or electrostimulation. So all those things can be done by a well-trained physical therapist focusing on bladder control and pelvic floor muscle control. We have just pads, or diapers, adult diapers, and Kelly clamps, which are actual clamps to the penis to stop leakage. These are all more conservative treatment options and certainly not right for everyone. One of the more permanent solutions, which I certainly enjoy because I enjoy operating, is a male sling. In the right patient, male slings can be an excellent option. This is generally reserved for patients with mild to moderate stress urinary incontinence, patients who have not had a history of radiation, and patients who just need a little extra support. And there's a slide here where you can see the tape, which is this mesh-like material. Now, don't be confusing this with the gynecologic mesh that was recalled. This is far separate. But this male urethral sling has a job of both repositioning and supporting the urethra. So when you cough, that urethra actually is compressed appropriately, maintaining continence and preventing you from leaking. So in the right patient, a sling can be a very quick outpatient procedure with excellent results in terms of continence control. For more severe patients on the moderate to severe side of the spectrum, or patients who have had a more complex surgical history or radiation, that's when we're thinking about artificial urinary sphincters. And this is essentially recreating a sphincter mechanism for your urethra that when you're not urinating is closed and you will be dry. And when you do need to urinate, will open up and allow that voluntary efflux of urine. So that's the artificial sphincter. And here in a nutshell is the device. Similar to the penile implant, the inflatable penile implant, there's a pump control unit within the scrotum that is all under the skin. It's kind of like pinching the skin on the back of your elbow. It doesn't hurt, and you can feel the pump underneath the skin. And when you need it, you find the landmarks and you squeeze. And what happens in this device is that this cuff here, which is your new sphincter, actually relaxes. And so it gives you 30 seconds of flow, and then it will close back down when you're done and be closed and keep that urethra crimped off so you don't leak at baseline. You don't leak when you pick up your grandkids. You don't leak when you go to the grocery store and load a carton of milk into your grocery cart. So these procedures are also outpatient. Usually there's an incision in the perineum, which is the area between the scrotum and the anus, and sometimes also an incision in the lower quadrant of the abdomen to place that little balloon. Generally, I don't activate these devices again for 4 to 6, sometimes 8 weeks afterwards to allow that cuff and that urethra to heal. And then we have our graduation day where we turn on the device and continence drastically improves. So I think that's very fun. Looks like I minimized my screen here. So let me try to pull this back up here. There we go. Hopefully you guys are still on the same screen here. All right. So yeah, in terms of patient satisfaction rating with the artificial urinary sphincter, or the AUS, extremely high, 90+%. And so 94% of patients would recommend this device to a family member. Typically is covered by insurance, particularly in the post-prostatectomy population, and very high satisfaction ratings with both the sling and the sphincter when used in the appropriate patient. I did want to touch on the risks with the male sling. Certainly, we again worry about infection and device failure. One of the separate issues in comparing AUS to IPPs is erosion. When you have this donut, this cuff surrounding the urethra, it can actually erode into the urethra. And that's something that usually we see down the road, 5, 10, 15 years down the road. And also you need to be aware not to allow anyone to catheterize you unless under an emergent situation, and preferably after the device is deactivated. So we actually give our patients specialized bracelets if they choose to wear those. Most patients just have a card in their wallet that can identify them as a sphincter patient. So that way, when they're being evaluated under an extreme situation, their healthcare provider can be cognizant of that. So yeah, in terms of stress urinary incontinence, very similar message as ED. There are fixes out there. There are conservative behavioral modifications which can help. There are minimally invasive surgeries, both in slings and in sphincters, that in the right patient both represent excellent options for restoring your continence. So with that, I think I'm going to wrap it up for now and allow us to gather some questions. Hopefully we have one or two by now, Jose, and I'll let you start firing away.
Sure. Yeah, I have a question here. Can I still have an orgasm after I get an implant?
So the question was, can I still get an orgasm after an implant? And the answer is absolutely yes. The implant itself, the penile implant, is just a mechanism to bring rigidity to the penis. It does not affect sensation, does not affect urination, and does not affect ejaculation. So once you heal, your sensation will be the same. Sex is just as pleasurable as before. And more importantly, perhaps it feels just as pleasurable for your partner. So sex remains the same for both yourself and your partner, and ejaculation and the act of orgasm are unchanged. Wherever you are, pre-surgery, it should be roughly the same post-surgery.
Great. Let me remind the audience, please use the chat box for any questions. I do have another one here that it says, is there an age when a man is too old to treat ED?
I like this one. No, the question was, is there an age when a patient or a man is too old to worry about treating ED? And I actually get this one a lot in clinic, and they say, Doc, I'm 85, should I just hang my hat up and be done? And the answer is, well, I'm a little biased, but the answer is no. If you're a healthy 85 and you are motivated and you have a partner and you're interested and it's a priority for you, then it becomes my priority, and there are treatment options out there. I think in recent memory, I had a 92-year-old who did a penile implant and did excellent with returns of healing in terms of his recovery. And he's so happy that he has an implant to use, and it's great. So no, age in and of itself, certainly not a factor. It's just a number. And I think more important is looking at that patient, looking at his lifestyle, his comorbidities, his medications, and going through step by step what you can do for that particular patient. So no, there's no age cutoff for any of these treatments. There's no age cutoff for surgical treatments. Certainly, if you have advanced stage or if you have comorbidities, you treat some of these more aggressive maneuvers with respect. But in reality, they're all minimally invasive options. So no, age in and of itself is not a concern.
And then I have another question here. It says, are there any vitamins or natural options for treating ED? So yeah, I guess over-the-counter GNC kind of,
Yeah. The question was regarding supplements or natural vitamins.
Correct.
To treat ED. And in reality, there are a lot, like yohimbine or horny goat weed, or just your black rhino from the gas station. In reality, the urologic literature doesn't really support any of these. They find them no better than placebo. Although I have some patients swear by things like yohimbine and etc. In my practice, I don't regularly advocate for them. I think that a well-dosed phosphodiesterase 5 inhibitor, meaning a well-dosed Viagra, a well-dosed Cialis, is the way to go. So yes, there are supplements out there, not much support with regards to the urologic guidelines and literature.
So here's the last question I have, unless someone else asks another question in the chat box. It says here, how expensive is the implant surgery, and is it covered by insurance? Yeah, you mentioned that most of the time it's covered by the insurance, but
Yeah, correct.
Yeah.
With talking about implant coverage, so inflatable penile implants, semi-rigid penile implants, in general, are covered by insurance companies. They are covered by Medicare, which is the biggest thing in terms of American healthcare, and most private insurers model their coverage based off of Medicare for the most part. We do run into the rare exclusion, in which case we have programs. Boston Scientific, for example, has programs in which we can work through insurance denials and try to get that authorization. But by and large, implant surgery is covered. And so, you'll have your deductible, but whatever that is, the surgery itself, the device itself, the recovery, the 90-day global, all of that is covered, yes. So we try not to let insurance itself be a roadblock to restoring your sexual life.
Great. So that was the last question I had on the chat box, unless anyone else, there's another one here. So let's see. I'm currently undergoing radiation treatment for prostate cancer. Is there a customary waiting period before considering exploration of the appropriate ED solutions?
I would probably say no. And this is a little bit more of a gray area, but I would be interested in knowing what this patient's sexual function was before radiation therapy and certainly during. I would certainly reserve any more aggressive, like surgical options, until radiation is done, the patient is healed, etc. So I'm not necessarily jumping to an implant while someone's actively getting radiation, but you can certainly have some of these other treatment options, the pills, even injection therapies, etc., while you're undergoing radiation therapy. I got to be blunt, most of my patients undergoing therapy aren't in the mood or aren't motivated. So I'm happy to hear this patient sounds like he's doing quite well, and that's excellent. But no, I would be willing to discuss other options, injection therapies, etc., while they're undergoing therapy. And certainly in the weeks and months that follow, if our treatment options are insufficient, there's no magic cutoff on when you can pull the trigger for something like a penile implant. I think that question in terms of the timeline would be more of a factor of the patient's age, comorbidities, background, and what their ED function was like prior. Because if they had bad ED going into radiation, I would be more aggressive coming out of radiation with my treatment selections. I hope that makes sense. I know I didn't answer it with a definitive.
Well, Dr. Beilan, we don't have any more questions. So thanks everyone for attending this webinar. I hope we answer all the questions. I believe we did. And if we miss anything, we'll be in contact via email. Thanks, Dr. Beilan, for your time. And why don't you just take it away?
Great. All right. Well, thanks everyone. And I appreciate you signing on. Please don't hesitate to come in. We can do a telemedicine visit. We can do an in-person visit, and looking forward to working with you if that's what you choose. Thank you.
Y'all have a great night.
Bye.